a bit of a inflammatory response to this area. Let's go in a bit higher. So pretty high-grade tumor. Looks like we can see some mitotic activity here. The nuclei are maybe a little bit eccentrically placed. Some of these tumor cells have fairly abundant eosinophilic cytoplasm, essentially undifferentiated looking in terms of the morphology. And so they're at high power. Again, you can see some of these cells have really quite abundant eosinophilic cytoplasm, what might be described as something of a rhabdoid morphology in this case. So let's look at a couple of stains. Here's a CK7, and maybe wouldn't be my first choice of stain if I just wanted to say, is this an adenocarcinoma or squamous cell cancer? But I think it's helpful to kind of look at this battery of stains in terms of trying to understand this lesion. Here's our glandular proliferation. You can see very strongly CK7 positive. One of the considerations here when the pathologist first looked at it because of the mucinous differentiation was, is there an enteric component here? Very strongly CK7 positive was CDX2 negative, so that probably was not the case. You can see that 7 is maybe focally positive in this more poorly differentiated rhabdoid component. Here's CAM5.2, fairly equivalent degree of keratin expression in those two components, the more glandular and solid component. And then there's this stain, SMARCA4. So this seems like it's kind of out of left field. Why would we do this stain? This was prompted by the morphology of this component here, rhabdoid morphology. We're increasingly recognizing is the correlate of finding SMARCA4 deficiency in our tumor cells. So we recognize SMARCA4 or BRG as a tumor suppressor gene that's altered in a variety of different tumor types. Small cell or hypocalcemic type small cell carcinoma of the ovary is one of those tumors that we know is driven by SMARCA4 deficiency. A handful of malignant rhabdoid tumors can be driven by SMARCA4 deficiency. And then there's this unusual appearance of lung tumors, including this rhabdoid morphology, that appears to be driven, at least in a subset of cases, by this SMARCA4 deficient phenotype. So this is the immunohistochemistry that demonstrates that this protein is lost in this tumor. I would point out a few things here. For one, we have very nice internal control staining in the immune cells. But again, you can see that the tumor cells themselves have no SMARCA4 expression. What's also interesting is that you can see there's no expression in the rhabdoid component. In addition, there's no expression in that better differentiated glandular component. So the question here is, what's the diagnosis? Based on what we now know about lung tumors that can have SMARCA4 deficiency, is that this would be best characterized as a SMARCA4 deficient lung adenocarcinoma with rhabdoid features. I think essentially what that tells us is that it's a tumor that's likely to have fairly aggressive behavior. In this particular case, it was actually fully resected based on what we could tell. And therefore, whether or not this tumor will be aggressive in this patient is hard to say. In his particular case, he actually had small cell carcinoma in his lymph nodes. So, and those were SMARCA4 intact. So in all likelihood, he actually had two processes going on, likely as a function of his heavy smoking history. For this particular lesion, again, I showed you some of these stains. It was actually TTF1 negative in both the glandular and the solid component. And again, CDX2 was also negative. So why do I bring this case up? I mentioned what SMARCA4 is. It's this a member of the SWI/SNF ATPase-dependent chromatin remodeling complex. We know that germline loss of function mutations can be seen in a subset of cases of rhabdoid tumor predisposition syndrome in children. We also know that it's a driving alteration in a subset of unusual tumors throughout the body. And that in general, these SMARCA4 deficient tumors show aggressive clinical behavior irrespective of where they are identified within the body. What about in the thorax? So we have two different entities that have now been described. We have SMARCA4 deficient non-small cell lung cancers and SMARCA4 deficient thoracic sarcomas. And the question that we're facing right now and that we're actually really struggling with, I think, as a field is what is the relationship between these tumor types and how does this distinction influence management? I think question number one is where did this entity come from? This was introduced into the sort of list of potential diagnoses that it can occur in the lung back in 2015. And this was described as, again, SMARCA4 deficient thoracic sarcoma as a large mediastinal or pleural-based mass arising predominantly in young to middle-aged patients, in men much more commonly than women. These tumors show no evidence of lung-specific differentiation, so typically you don't see either TTF1 or P40 expression. It was originally defined by a French group led by Leloire, who based the classification of this lesion based on gene expression profiles that closely resembled those of other known SMARCA4-driven tumor types, such as the small cell hypercalcemic type of the ovary, as well as SMARCB1 deficient malignant rhabdoid tumors. And that, of course, is another member of this complex. Immunohistochemically, we know that SMARCA4 deficient thoracic sarcomas are SOX2 and CD34 positive and tend to be Claudin-4 negative. They typically don't show much keratin expression, but they can show a little bit. There are no other oncogenic driver mutations observed based on the genomic studies of this tumor type. Only the SMARCA4 and maybe a P53 mutation, but you don't see things like KRAS mutations or EGFR mutations in these tumors. These are very aggressive tumors. They typically present as stage 4 with median overall survival of about 7 months from the time of diagnosis. What about SMARCA4 deficient non-small cell lung cancers? As opposed to these thoracic sarcomas that have been described, which appear to be more of soft tissue mediastinal masses, these tumors more clearly arise within the lung parenchyma. They can show better differentiated areas, as in our case with abrupt dedifferentiation. You can expect keratin expression routinely. They may have TTF1 expression or rarely P63 or P40 expression. You can see some variable SOX2 positivity, but they typically are CD34 negative. You can often see oncogenic mutations observed, especially KRAS, because these are very heavily associated with smokers, and KRAS tend to be enriched in that group. And as in our case, these can be seen in patients who have earlier stage disease. And I think as a result of the fact that we have these really mixed cohorts of tumors that have been described, and they're still relatively rare, that the overall survival for tumors primary to the lung with this change has not been well established. I think one of the questions we're facing as a field now is whether SMARCA4 deficient thoracic sarcomas and non-small cell lung cancers might actually be the same lesion presenting at different stages, essentially. Both of them are actually exclusively or pretty much exclusively observed in heavy smokers based on the available published data. We see frequent rhabdoid features in this so-called thoracic sarcoma. We can see some clear cell change as well as rhabdoid features in the non-small cell lung cancer with SMARCA4 deficiency. Both of them show very high tumor mutational burdens as a result of smoking, and you can perceive that smoking mutational signature in these tumors quite frequently. Excuse me. So I think at this point, we are dealing with a question of what exactly comprises this spectrum of SMARCA4 deficient thoracic malignancies. It looks like this is a subset of undifferentiated large cell type tumors of the lung, some of which may have rhabdoid morphology, and probably helps to describe some of those tumors that existed in prior versions of the WHO classification, such as rhabdoid type non-small cell lung cancers. This is likely the underlying genetic alteration in those tumors. In theory, we can distinguish the carcinoma from the sarcoma based on this differential immunohistochemistry expression. High levels of SOX2 and CD34 in the sarcoma, low levels of Claudin-4 in the sarcoma, the opposite expression profile in the carcinomas. Oops, I'm sorry, let's go back. I think the final take-home I'd like to mention, though, is that the clinical implications of this distinction have not been established. So when we have a case like this, that immunohistochemically, maybe it's predominantly in the lung, immunohistochemically it looks more like a thoracic sarcoma as has been described, and we make that diagnosis, the patient may be seen by the thoracic oncologist because that's how they present it clinically. The thoracic oncologist says, but you called it a thoracic sarcoma. I'm going to send it over to our sarcoma oncology colleagues. And they'll say, we've never heard of this before. What would you do on the thoracic oncology side? And so ultimately, I think the management of these tumors is very much unclear. So again, clinically, they tend to present as a lung cancer would, and I think the default is often to treat them as lung cancers, but we really don't have good data on the best approach. What we do know is that when they do present at an advanced stage with mediastinal involvement, they tend to be very aggressive and I think generally pretty refractory to therapy. There are studies, particularly in the pediatric population, for things like malignant rhabdoid tumors, where they're starting to see some more targeted therapies against the SWI/SNF pathway alterations. In particular, EZH2 inhibitors have shown some promise. The question of whether those will have any utility in the heavy smoker context like this, I think remains to be seen. So I think let's see what happens with the WHO classification, which will be coming out in the next year or so, and how this gets handled in that context, whether or not there will be a consensus that we need to have separate entities for a thoracic sarcoma and a carcinoma. I think it remains to be seen. We probably don't have enough evidence to date to support the presence of them being either distinct entities or a single one. So more to come on this topic. Has anybody seen a tumor like this in their practice? You didn't put a fancy name on it, and it sort of remains to be seen what the clinical implications of identifying this specific genomic alteration in these tumors really is. I think that the jury is out somewhat in terms of whether these are more or less responsive to immunotherapy. I think there have been some studies to suggest that they be more responsive and others that they're less. So not enough data at this point. Okay, second case, 60-year-old gentleman. He has a known EGFR mutation, a diagnosis of lung adenocarcinoma, and he is progressing on erlotinib therapy. We offer targeted liquid biopsy testing at our institution. We have a focused PCR assay that's very sensitive for detection of EGFR exon 19 deletion, L858R, and then the T790M mutation. In his particular case, he had advanced disease, he was progressing. They sent us a plasma sample to look for the T790M mutation, which we detected in his case, along with his exon 19 deletion mutation. Based on identifying that resistance mutation in the plasma, he went on to receive osimertinib, the next generation tyrosine kinase inhibitor that's effective in that context. Unfortunately, even though he should have responded nicely with that drug based on the clinical trial data, his disease actually progressed very rapidly. So at this point, a tissue biopsy was obtained to understand the mechanism of his resistance. So this is his tissue biopsy. It's a core biopsy of a liver lesion, and you can see that there's fairly clear-cut gland formation in at least a subset of this tissue. And then you can see there's other regions of the tissue that show somewhat smaller looking cells with a higher nuclear to cytoplasmic ratio, maybe some more nuclear molding. And interestingly, you can see some of these areas are actually very intimately admixed with the more glandular component. Here it is at higher power gland formation, and then this smaller population of cells, and maybe two mitotic figures right there. It's a little hard to tell from this angle. Again, this population of smaller appearing cells, more nuclear molding. I'll show you one immunohistochemistry stain, maybe not my favorite immunohistochemistry stain in the world, but it shows the distinction of these two populations quite nicely. And that's there, synaptophysin. So here's that glandular component, it looks negative. Here is that smaller blue component with molding, and I think here the nuclear morphology is even clearer than on the H&E. I would consider this to be a component that's undergoing a small cell transformation from this glandular component here. So we had molecular profiling performed as well for this patient from the tissue. Remember previously we only had the plasma results. We see again his exon 19 deletion mutation present at very high level. There's a low level of EGFR T790M, that's a subclone containing the resistance mutation. We see a high level of an RB loss of function mutation as well as a very well characterized pathogenic P53 mutation. So as we discussed earlier, RB mutations are essentially always present in small cell carcinomas. And it turns out that they actually can anticipate the development of small cell transformation in patients who have lung adenocarcinomas containing EGFR mutations. So the diagnosis in this case is an EGFR mutated lung adenocarcinoma with small cell transformation. Clinically, what this will do is trigger a use of a small cell type of regimen for the patient. The patients will respond to a small cell chemotherapy in this case. But as with small cell, in the setting of a smoker with a de novo small cell diagnosis, they typically will have relatively rapid relapse on that regimen. So how does this happen exactly, this path from adenocarcinoma to small cell carcinoma? And I think this published schematic from a couple of years ago is actually very similar to what we're seeing in our patient here. We're seeing a heterogeneity in terms of the clones that evolve from patients with EGFR mutated lung cancers. But what's very interesting is that these RB and P53 mutations are typically present from the very beginning. So the patient, we go and find this EGFR mutation and we treat accordingly, but in a subset of cases, these mutations are present as well, again, from the very beginning. And what appears to happen is that when these mutations are present, it allows the tumor to select for the development of at least one subclone that can undergo small cell transformation. And as with our patient, you can see one clone developing the T790M mutation and having an outgrowth of resistance that can be responsive to things like osimertinib therapy, but with a more major clone undergoing this small cell transformation with acquisition of a couple of other mutations along the way. About 5% of patients who relapse on first-generation EGFR TKIs like erlotinib or gefitinib will have small cell transformation as the mechanism of relapse. Rarely, but can happen as a de novo change. So we will have patients who are never smokers who present with small cell carcinoma. When we see that, the first thing we think about is the possibility of an underlying EGFR mutation with a de novo small cell transformation at presentation. The genomic features that anticipate small cell transformation, so you have a patient with a known EGFR mutation, how do you know which patients are going to go on to get small cell when you treat them? When they have P53 and RB at the time of diagnosis in their tumor genome, they have a 6-fold increased risk of developing small cell transformation than if they don't have those mutations and receive EGFR TKIs. What actually drives the development of small cell in this context, I think, is not entirely clear, but the alterations that we see kind of accumulating during the course of therapy include hypermutation via ApoBec mechanisms, as well as whole genome doubling. So whether these are causative or whether these are secondary to that transformation process, I don't think we know yet, but there are clearly a number of very complex genomic alterations that occur as small cell evolves in this context. Yeah, go ahead. So the question is whether the EGFR TKI therapy triggers the transformation, and I think that's probably exactly what's happening in a subset of these patients. I think it's hard to know because the natural history of an EGFR mutated patient who's untreated is hard to query because we almost are always treating patients. If we are prospectively looking for RB P53 mutations at the time of diagnosis and then can treat them differentially based on knowing that status, maybe we can get at that question, but I think it's not clear. For us in the United States, where osimertinib is now the first-line choice of therapy for EGFR mutated patients, I think the question remains, are we going to see more or less small cell transformation? Osimertinib is a very potent EGFR inhibitor, and we're seeing all sorts of very strange resistance mechanisms when we treat with that drug. The question, I think, is will we see an even greater, instead of a 6-fold increase of transformation to small cell, will that go up even higher to a 10 or a 20-fold increase? I don't think we know yet, but I think the more we play with the biology of the tumor by giving these different drugs, the more we see very unusual mechanisms of of tumor biology. Okay. So our third case, any other questions about that case? Okay, so our third case is a 65-year-old man. He has an 8-centimeter right hilar lung mass, extensive lymphadenopathy, and vertebral column metastases, very extensive disease when he presents. I should also point out that he has an extensive smoking history. So he has a biopsy performed of his vertebral column mass, and you can see it here, very blue. So this may be one of those cases where, without even putting it on the microscope, you may have a high level of suspicion for what the diagnosis is in this case. So here is a higher power view of his tumor, and high nuclear cytoplasmic ratio, a large number of apoptotic cells, lots of crushing, a lot of nuclear molding. What's interesting, though, is that you have this, and you have this. Here's a higher power view. So what do you want to call this thing? What's the diagnosis?
He's a de novo patient, right?
De novo patient, yeah.
It's a double, two components.
Yeah, so combined tumor, yeah. Combined small cell adenocarcinoma, yeah, exactly. That's exactly what we thought this was. Here's our MIB, which I think is a little bit washed out. Apologies, it's high. It was a bit variable. It was actually, when you specifically looked at the small cell component and the adenocarcinoma component, it was a bit higher in the small cell than in the adeno component. So here's the full IHC workup. I found this case to be very challenging. It wasn't my case, thankfully. It was somebody else's, and they showed it to me. But it was a great case. As you'd expect, the glandular component had strong keratin expression, both in terms of AE1, AE3, and CK7. And it had focal dot-like expression of those markers in the small cell component. It actually had some patchy NKX 3.1. That's the marker we're using for prostate cancer in our laboratory, that we interpreted as patchy and nonspecific. He'd had a very vague, very poorly recorded history of prostate disease. We don't know if he had benign prostatic hyperplasia or prostate cancer, but based on this prostate history, we decided to get that marker and ultimately weren't quite sure how to interpret it. He had, again, a high level of MIB in both components, and RB, it turned out to be intact in this tumor. And you'll recall that I keep saying that RB is almost universally mutated or inactivated in our small cells. So this is a bit of an interesting observation. Now, does that rule apply to combined tumors? I'm not so sure. It seems like it should, but maybe not. You can see in the small cell component, we had some focal TTF1, we had some weak synaptophysin, as I showed. Or that wasn't this case, different case. Very high MIB, and then again, the intact RB. And you can see a variety of other markers that were negative in both of those components. So that's our final diagnosis. And now, based on this, combined adenocarcinoma, small cell carcinoma, the oncologist said, you say he has a component of adenocarcinoma. Is this a de novo EGFR mutated tumor? Let's make sure we get molecular profiling in this case. So we started by doing our immunohistochemistry for our predictive biomarkers, ALK, ROS1, and PDL1, and got this surprising result. So we had positive ALK IHC in the small cell component, although it looks like it was negative in the adenocarcinoma component, but this was very unexpected and led us to think that we should probably do some confirmatory molecular testing. ROS1 was negative, PDL1 was negative as well. At this point, molecular profiling was pending. So there's the ALK IHC result. So again, here's our glandular component that appears to be negative. Here is our small cell component that it's weak, but it's diffusely positive. And I was speaking to somebody at the break where when we have a true positive ALK result, it's almost always a diffuse positivity. Usually it's quite strong as well, but if the pre-analytics are a little weird, fixation was too long, et cetera, you can see some diminishment in that expression level. There's probably some degree of biologic variation in terms of the amount of ALK you see in a tumor as well. So based on this, we thought we better get ALK FISH testing to confirm, and it was negative. So no evidence of a rearrangement. Polysomia was identified, i.e. more than 2 copies in close to half of the nuclei that were counted, at least confirming that we tested the neoplastic component. The next generation sequencing results came out soon thereafter, all very interesting. Very low tumor mutational burden, which is very unusual for small cell. Mismatch repair proficient. This is something we do routinely with our next-gen testing. And then we identified essentially a complete deletion of PTEN. So this appears to be the driver in this case. A P53 mutation you can see in the vast majority of the reads. No other targetable alterations or other oncogenic driver mutations. So an integrated diagnosis in this case, if you have the opportunity to make one, is an unusual combined adenocarcinoma and small cell carcinoma that appears to be driven by biallelic or homozygous loss of PTEN, which again, going back to the prostate history, makes you wonder, because PTEN is such a commonly lost alteration in prostate, whether this could ultimately have been a terrible metastatic prostate cancer, although the clinical and radiographic appearance was not really in keeping with that. So ultimately, this may be one of our RB intact small cell lung cancers with a very unusual phenotype. What happened with him clinically? He actually received small cell type therapy, 5 cycles, and he actually had a very good response, but incomplete. And he had, as he progressed, he was actually changed over to pembrolizumab therapy. Again, I think more to do with the adenocarcinoma component than the small cell component. And unfortunately had major respiratory compromise when he was on the pembrolizumab and died of progression of disease within a month. So a bit of an unsatisfying case because we don't necessarily, it's hard to classify his tumor, but I think the ALK IHC result is informative, or at least it's a pitfall that you should be quite aware of when you're performing that type of testing in unusual contexts like this one. There are a number of case reports and case series that report ALK expression in small cell lung cancers that cannot be confirmed by FISH or molecular methods. The frequency of this abnormal expression is not entirely clear, but some series suggest it's up to 5% of cases. And it's been reported in a few other contexts as well, as including Ewing sarcoma. In fact, we have a publication from several years ago where we performed ALK FISH testing based on an IHC result in what was originally thought to be an atypical carcinoid tumor, on which we performed molecular testing. There was no ALK rearrangement despite the presence of protein expression, and then we identified the EWS rearrangement in that case. So very unusual context. You can see some aberrant ALK expression. Important to keep that in mind when you're interpreting these results. Okay, any questions about that very unusual case? Yeah. Not, yes, yeah. Yeah, so so we actually see a lot of nut carcinomas in our practice because we're a referral center for them. So we have a very low threshold for ordering nut immunohistochemistry. It would be an unusual presentation in this case to have a combined glandular and small cell component. It's almost always a poorly differentiated or undifferentiated carcinoma with abrupt squamous differentiation as opposed to glandular differentiation. But I think it was such an unusual case that the decision was made just to get that IHC stain, and so we did. It's easy because we have it in our lab. Yeah. Okay, our final case, a 70-year-old woman who's a non-smoker with a history of breast cancer. And you can see the details about the breast cancer there, is now presenting with a 5-centimeter right lung mass with chest wall invasion. She undergoes a diagnostic biopsy, followed by neoadjuvant therapy and surgical resection. So I'm not going to show you the diagnostic biopsy. Suffice it to say, it was diagnosed as a lung cancer, and it underwent neoadjuvant therapy accordingly. They managed to shrink it enough that they could perform an adequate surgical excision, including a chest wall resection. And here is a low-power image of that tumor. You can see a very well circumscribed tumor, obviously clearly situated there within the lung parenchyma. Here's a higher power view. We'll go a bit higher. So keep in mind she's a never smoker. I guess question number one, is this her breast cancer? Probably not. I guess it could be possible, but probably not the case. And it certainly doesn't appear to have adenocarcinoma morphology, so let's just look at it a little bit higher power. And I think aside from a couple of very beautiful mitotic figures, you can see really very clear-cut intercellular bridges present here, a lot of abundant eosinophilic cytoplasm. Morphologically, it's a squamous cell cancer. So it's an unusual situation. We have a never smoker. The tumor is actually arising on the contralateral side from her breast cancer, so it's not within the radiation field for her breast cancer. So it's a question of why is this woman developing a squamous cell carcinoma of the lung in the context of a never smoking history. There is some immunohistochemistry just to support that diagnosis, even though I don't think it's necessary in this particular morphologic context, but given that she's a never smoker, it's useful to see that information. Relatively poor response to her neoadjuvant therapy. So she actually got tumor genetic profiling. She didn't have metastatic disease, but given the unusual clinical context, profiling was performed. And this is what we found. So she actually had a fairly significant family history of breast and ovarian cancer as well. And she had prior germline testing that demonstrated that this particular BRCA1 mutation was present in the germline. You can see that in her tumor, it's present at a very high mutant allele fraction. So presumably, all of the tumor cells have this mutation, as well as a second copy of BRCA1 is inactivated in the tumor cells as well, given how high this frequency is. So presumably, this is the dominant driver in the patient's tumor. You can see a variety of other tumor suppressor genes that are mutated as well. So I would just point out a couple things about testing squamous cell cancers in patients with lung cancer. Usually doing molecular testing of squamous cell cancers is not very high yield in terms of identifying targetable alterations. And this gives you a sense, this is from our own genomic analysis of the patterns of alterations that we see in squamous cancers. I would point out that you don't see much in the way of targetable oncogenic alterations in most of these. It's typically a lot of different tumor suppressor genes and then amplification events in various either differentiation markers or cell cycle proteins. If, however, you start to break down the pattern of genomic alterations in never smokers and heavy smokers with squamous cell cancers, the pattern looks very different. So light or never smokers with squamous cancers can have MET splice mutations, like we talked about earlier. They can have EGFR activating mutations. You can also see a subset that have biallelic or homozygous loss of function BRCA mutations, including in BRCA1 and BRCA2, including patients who have germline alterations. And in fact, this is a cohort of patients that we sequenced in our own institution, and 2 patients that were unrelated had the same germline BRCA1 mutation, family history of breast and ovarian cancer, and both had developed squamous cell carcinoma. So we suspect that a subset of our patients who have hereditary breast and ovarian cancer can have other unusual tumor types, including squamous cell carcinoma of the lung. And one other point that I would make, and this is, of course, United States, northeastern enriched population of principally Caucasian patients who are seen at our institution. A third of patients who have non-smoking history, who have a squamous cell cancer, have a very high mutational load in their tumors. When you actually interrogate those mutations, you find that the pattern of mutations is consistent with what you'd see resulting from UV exposure, so ultraviolet light exposure. And when you delve into those patients a little further, you'll find that they have a history of cutaneous squamous cell cancers. So we suspect that a third of the time when we have never smokers with squamous cell cancers, that the real diagnosis is metastasis from a cutaneous squamous cell cancer, not primary lung squamous cell cancer. And that's, again, based on this mutational signature that we can see that's very characteristic of what you see from sun exposure. So the take home there is that there are actionable oncogenic driver mutations in a small percentage of squamous cell cancers, almost exclusively in light and never smokers. In our experience, about a third of lung squamous cancers in never smokers are metastatic from skin primaries based on mutational signature profiles. We're seeing an enrichment of homologous recombination pathway gene alterations in light and never smokers, including in BRCA1 and 2 germline carriers. And then finally, that molecular profiling of tumors from heavy smokers tends to yield few clinically actionable findings, which is very consistent with what's been published in the past on these tumor types. And that's all I have. Happy to take any questions. Okay. Okay. Thank you. Okay.
Okay, so like